Are you someone who's interested in medical coding? Maybe you're thinking about this as a future career path, or you already work somewhere in healthcare and you just want to know a little bit about medical coding, enough to get through the day. Well, you're in luck, because today I'm going to be talking about the beginner's guide to medical coding. Hey everyone, I'm Victoria. I'm a medical coder, auditor, educator, and content creator, and on my channel I provide tips, tricks, and tutorials to help you be successful in a medical coding career. Today we're going to go over Medical Coding 101, the beginner's guide, and make sure you stick around till the end because we're going to do some hands-on coding cases. So let me start out just saying, with medical coding, it is not something that you need to have even an associate's degree or a bachelor's degree in order to become a certified coder. Most employers are just looking that you have a certification through AHIMA or AAPC. I myself am a very proud community college girl. I went through their career programs and I have a certificate as a medical billing specialist, and then I became certified as a professional coder from the AAPC. There are just so many amazing opportunities in medical coding, and if you take advantage of all these opportunities, you are going to have an enormous amount of different growth potential to get into things like compliance and auditing and specialties. There's even certain specialties in medical coding like interventional radiology that pay a lot of money. Medical coding is reviewing medical records, analyzing them, abstracting certain pieces, and then converting them into medical codes. Now, sometimes all the pieces aren't there. You might need to go back and have them correct the documentation so that you can abstract the best code possible, but that is a very simplified process. So medical coding involves every diagnosis and procedure known to man, and as part of a healthcare team, you do need to understand things like medical terminology and anatomy and physiology so that you can be the best coder you can be. Now, medical coding is not just for reimbursement, but that's the first thing that comes to mind because we hear this term medical billing and coding and we think, oh, these are kind of tied. Sometimes people do both. Sometimes there's a biller, sometimes there's a coder, and one does billing, one does coding. So medical coding does not just serve purposes for billing and reimbursement. There is also a lot of data in it because we need to track how many patients have certain diseases and how often those diseases progress into something else, how many times those patients have complications, and there are different codes to identify that. There's a code for a patient that has diabetes, and there's all kinds of different codes for diabetic complications, and that way we can look at those data analytics and determine how many patients that have uncomplicated diabetes are likely to develop some kind of complications. What complications are they developing? And then we can look at other things like, well, what services did the patients who didn't develop complications receive? Are these services that we should start giving to patients so that we can cut down on healthcare costs? So there's a lot more involved in medical coding than just getting reimbursed from insurance companies. And there's different code sets that we use, and depending on what type of coding you do, you might use all of them or you might use only one of them. There is professional coding. That's the most popular one that medical coders get into, where you use ICD-10, CPT, and HCPCS, but we also have things like the ICD-10 PCS. Let me show you some of the books I have for medical coding. So this is my ICD-10 CM manual. This is the International Classification of Diseases version 10, and this is the CM, clinical modification. There's different versions of ICD-10 that are used throughout the world, but the CM version is the one that's used in the United States. So other countries have a different abbreviation here for the version that they're using in their country. So ICD-10-CM is diagnosis codes, and then other little codes that give information about things like if you're at risk for developing cancer, you have a family history of cancer, you're coming in for an encounter for your routine physical exam, so maybe there's not necessarily a diagnosis there, but we have a diagnosis code to identify, oh yeah, this is a patient who's presenting for their routine physical exam. Then we have our CPT code. CPT is current procedural terminology. So CPT, this is my 2021 edition. So depending on what type of coding you do, you might not use CPT. If you do inpatient coding, you might not do a lot. If you do risk adjustment, you're not going to use any CPT. But CPT is current procedural terminology, and this is published by the AMA. And these are all the different medical services and procedures. So this HCPCS book we call HCPCS. It is the Healthcare Common Procedural Code Set. It has durable medical equipment, drugs, and then there's some insurance-specific information and services as well. And then ICD-10 PCS, I actually don't code for ICD-10 PCS because this is used in inpatient coding, and I don't do inpatient coding. I do pro-fee, outpatient, and risk adjustment coding. So this is ICD-10 PCS, and this is the ICD-10 procedural code set, and that is for inpatient coding. You know what? I almost forgot there's another code set, CDT, which is the dental code. So I've never coded for dental. I don't know a lot about dental coding, but that is an additional code set specifically for dental coders. If you're interested in learning about the best medical coding books to get, not just ones to learn the code sets, but also to learn how to code and learn MedTerm too, I have a great video on my best recommendations for medical coding books. You can find it here in the tag, and then I will also link it in the description below. Now, if you're interested in learning about the typical day in the life of a medical coder, I have a whole video on that. You can check that out here and in the description, but let's talk about salary. So according to the AAPC salary survey, the average salary for a certified professional coder is usually around $57,000. Now that's average. That includes the people who have 20, 30 years experience. Starting salaries are more like $38,000 or so for starting wages for professional coders. Now this varies a lot depending on your state, your country, and there's a lot of information that goes into it. AAPC actually has a salary calculator that they use. They have information about different regions. I have a video specifically on salaries for medical coders. Again, check out that link and I'll put it in the description below. Medical coders can work in a lot of variety of places. They could work in provider offices, they can work in hospitals, they can work for insurance companies, they can work for vendors, they could work for lawyers in the legal sector. There are coders that work just for companies that hire coders, that they're kind of outsourced companies. They just do billing and coding. They could work anywhere in the revenue cycle. And there's a lot of opportunity for growth in medical coding. You can specialize in certain types of coding, like you could do just cardiology or urology. Oftentimes, the more and more specialized your niche is, you can make more money, but having that broad range of knowledge is exceptional as well. So medical coding is not as simplified as some people think. They feel like, oh, it's just kind of looking up things like you would in a phone book and you assign the right number. Like if I look up John Smith in the phone book, I'm going to find John Smith's phone number. It's not quite that simple. There's a lot of analyzing that goes into medical coding, a lot of interpretation, a lot of reading goes into medical coding, and understanding that you're part of the healthcare team. You do have to know some clinical information and understand the impact that incorrect coding can have on finances. So I'm going to talk a little bit about professional coding. Professional coding is coding for provider-based services. So your doctor doing your physical exam, your surgeon doing your cholecystectomy, all of the different services and procedures that are provided by providers, versus inpatient coding, where they are coding for services that you were formally admitted to the hospital and coding for that whole inpatient hospital stay. There's also risk adjustment coding that just works with diagnoses. Then there's outpatient coding, which is services that were provided in an outpatient facility like an ambulatory surgical center. Let's actually start with the ICD-10-CM book. So there's a couple sections to the ICD-10-CM book. At the very front, you will find your alphabetic index, which is the A to Z listing of terms that you're going to look for diagnoses and other types of encounter status types. Now, one of the first things you have to do is locate your key term, and that key term can be easy if it's just a one-word diagnosis, but if you've got a diagnosis that's 6 or 7 words, you have to figure out what that key word is. And I'll talk about this as we go through our demonstration. So what you do is you find your key word and you look in the alphabetic index in the front. So I'm looking right now at the page that says infection, and there's tons of different infections. So if I'm looking for an infection, I have to narrow that down. So is there an infection? So here we have infection of the pinworm. It says infection pinworm is B80. So once I've found that code, I can't just assign B80. I have to verify that in what's known as the tabular list. So the tabular list is back here. Now this alphabetic index isn't just the only alphabetic index we have. We also have a couple of tables. So there's the general alphabetic index. Then we have a table for drugs and chemicals. So those are things like poisoning and self-harm with different types of substances. And that could be a substance like alcohol. It could be different types of medications. And then we have our table of neoplasms. So that's commonly used for things like cancer or carcinoma in situ, or even benign lesions. So this is the same table we would use for things like moles and other lumps and bumps that a patient may have in different areas. And then we have the index for external causes of injury. And those are the ones that people find more humorous codes in, because the diagnosis codes that we have are not just things like cellulitis and inflammation and pain and headaches. It's also things like being bitten by a cow, being sucked into a jet engine, or even injured while knitting. So ICD-10-CM you can get for free. There are free versions that you can get through the CDC or through CMS. They are not formatted like an ebook. They're in all kinds of different PDF files. There are some tricks I'll probably show in a future video where you can take those and kind of format them into one full PDF ebook. But this you can get for free. And again, you look things up in the alphabetic index, verify it in the tabular. I'll take you through a couple of cases. So with ICD-10-CM, you look up in the alphabetic index, verify in the tabular list, and sometimes it'll give you additional instructions. It'll say, hey, this condition that you're looking for isn't included here. Or it'll say, hey, we need you to code something else first before you code this. Or you need to code something else after this. Or, hey, this code might not be the best. Maybe look for this. Or, hey, or they might say you need to verify that this is the right wrist or the left wrist, or was it bilateral? And there's a lot of guidelines that have to be followed in ICD-10-CM. There's pages of them and pages of them, usually at the front of your book. Some editions have them in the back. You can download them for free as well. And I actually have a whole playlist just about the ICD-10-CM guidelines. I go through the whole shebang. So it's sequencing things. It's about when a patient presents for this condition and they also have this condition, this is what goes first. This is when you can code for this, you can't code for this, and a lot of really nitty-gritty details. And then there's even additional stuff kind of going on behind the scenes, but I'm not going to talk about that for this video. Hey, if you're enjoying this content, you definitely want to make sure that you subscribe and hit that notification bell so you can get alerts when I post new episodes. CPT, the index is in the back. So there is an official guidance with CPT of how you have to look it up. So there is with ICD-10-CM, you have to go to the alphabetic index, verify in the tabular list, look at all the additional instructions. With CPT, there isn't an official way that you have to look up. So there are different chapters broken out by body systems. So for example, we have one that is cardiovascular, we have digestive, and then we have other sections like medicine services or evaluation and management, which are things like your providers just kind of doing an exam, getting your history, making some decision-making processes. You might think about it as something like your PCP visit. You're going in to see your primary care physician because you have chronic conditions he's managing, or he or she is seeing you for an upper respiratory infection, so they're determining, what your course of treatment is going to be, and those office visits are based off of different levels, and there's all kinds of code integrations that go into how we figure out what that level of service is going to be. So with CPT, you can look it up in this alphabetic index and then go to that particular chapter to verify it, or what some coders do is they go to the specific chapter. So each chapter has a table of contents in it. So for example, this is the surgical digestive system, and they go into lips and all the other different areas. So if you're looking for something that's maybe an incision or excision of the stomach, you would go down here, try to find the section that says stomach, and then you would go into, okay, what's the thing we did to the stomach? Did we do a biopsy? Did we do an incision? Did we do an excision? What did we do? And just kind of locate the code through searching that way. So the CPT book is all the procedures and services that could be done to a patient. And then we have what's called bundling. So for example, if we're doing a hernia repair on the patient and we open them up to repair the hernia, obviously we're going to close them. So even though there's different codes for closures, that's included in that code for the hernia repair, because if we open them up to repair a hernia, we're going to close them back up. So we don't code that additional code for closure, we just code the code for the hernia repair because it encompasses everything typically involved in repairing a hernia. Now CPT is maintained by the AMA, so they own all of the rights, and they do not provide any of the materials in the CPT index for free. There's one resource you can use to kind of look up some descriptions, and you can only do a limited amount of them, but generally speaking, you need to purchase the CPT book. There is also an ebook version. I actually prefer my paper version. Even though I'm a very techie person, I have the ebook of the CPT, but I like my paper book. Now, each chapter has specific chapter guidelines, and then there's even some guidelines in addition to that. So if you look at the section for removing a lesion, like a mole on your arm or your trunk, it goes based off of things like location. So you need to know in the documentation, where was it located? What size was it? And there's even guidelines on specifically how we determine what size we use for code selection, because there might be different sizes documented, and we might even have to do a little bit of math. If you're concerned about the math, I have a video on that too, about how much math is involved in medical coding. So this page, for example, gives us all the guidance that we need for how to select the appropriate size for excision of a lesion, and how we measure and how we figure out what the measurement is that we use for code selection. So now let's dive into a couple of cases so I can show you hands-on what it looks like when you are coding some medical records. So this first case that I want to look at with you guys is a carpal tunnel repair. So this is a surgical procedure that we're going to code. So this one, we have a preoperative diagnosis and a postoperative diagnosis. You'll see these in most procedure and surgery codes. So in this case, we have right carpal tunnel syndrome is our pre and post-op. You may see this change sometimes if the patient had something discovered during surgery. They went in, they opened them up. It wasn't what they thought it was going in, so that might be different. So we always code based off of that postoperative diagnosis because that's usually the more specific of what we're looking at. The other thing to consider is pathology. So we might open this patient up to remove a tumor, and then we send that tumor to pathology and discover if it was cancerous, it's non-cancerous, what type of tumor is it. So if we have something where we sent a specimen, we wait until we get that report back of what was that specimen, because that's going to be the most specific diagnosis, and that's what we're going to use for what we're coding. So if we look here, this patient had right carpal tunnel syndrome. Right's going to be important, and then the whole diagnosis. And then the procedure was performed on the right side, and that's going to impact some things we do with our coding as well. So this was a right carpal tunnel release. And even though we have this procedure listing here, we never code directly based off of just this procedure performed. We have to read this whole operative report to verify that this is exactly what the provider is describing down here. Sometimes there's extra things, sometimes they omit things, sometimes they don't put a size in incorrectly that we might have to go back to this provider and go, hey, we can't code this the way that it needs to be for this procedure that was performed because you omitted this little piece of information. Can you add that back in? Or maybe there was just something that wasn't 100% clear. So it's always important to read this. Now this is, I would say, a medium to small size operative report. There are ones that are quite long, sometimes 3-4 pages, depending on what was done with that patient, and you may have to read it a couple of times in order to abstract all of the codes to the highest accuracy and then verify if some of them are already included in other codes. So it isn't just as easy as looking it up in the book and signing the code and then you move on to the next case. There's a lot of reading and analytics involved into it. So in this case, the procedure note says the right upper extremity was prepped and draped in the usual fashion. IV sedation was applied by the anesthesiologist. A local block using 6 cc of 0.5 Marcaine was used at the transverse wrist crease using a 25 gauge needle superficial to the transverse carpal ligament. So this is the anesthesia portion of it. And we're not coding for the anesthesia because we're coding for the surgery. We're coding for the surgery itself. So this is the upper extremity was exsanguinated with a 6-inch ACE wrap. And then this is their tourniquet time, less than 10 minutes. So here is what we need to really read, dive into, and then abstract the important pieces. This is the body of the operative report, and this is the step-by-step provider's description of what they did. So an incision was used in line with the third web space just to the ulnar side of the thenar crease. It was carried sharply down to the transverse wrist crease on the right wrist. And this is the important part. The transverse carpal ligament, because that's what we're working on, right, was identified and it was released under direct vision. Proximal to the transverse wrist crease, it was released subcutaneously. Good. So during the entire procedure, care was taken to avoid injury to the median nerve proper, the recurrent median, the palmar cutaneous branch, the ulnar neurovascular bundle, and the superficial palmar arch. The nerve appeared to be mildly constricted. That's why they are doing that release. Closure was routine, running 5/0 nylon, a bulky hand dressing, as well as a volar splint was applied, and the patient was sent to the outpatient surgery area in good condition. So the important thing about this is they're basically saying we didn't accidentally nick any of these nerves, and if they did, that's actually not something we can bill to the patient. There's sort of a you break it, you buy it policy with surgeries. If they go in and they accidentally break something else, that's not something that gets billed to the insurance or sent for patient responsibility. It's something that the hospital just kind of has to eat. Although sometimes, depending on how it's organized, you might have to code it out and then they just write that code off because they want to maybe keep track of it. So then we just have the closure here. Now, anytime a patient is opened up, it stands to reason they're also going to be closed. So in the majority of cases, closure coding is included. So you don't code additionally for suturing the patient closed. So let's look at this. We have a diagnosis that we're going to need to abstract, diagnosis, and then our CPT code, right? So our diagnosis here is the same. We didn't find anything else in here that looked like maybe this was not correct, or we needed to maybe look at a different code or get clarification. It was a right carpal tunnel syndrome. So with ICD-10-CM, we always look for the key word. What's our key word that we're going to look for in the alphabetic index? What are we going to start with? And it's suggested to not start with a body area or system or part, because the reason is if I want to start and look at the word wrist, it would tell me see condition. And what that means is don't look at the word condition. It means what is the condition of the wrist? Is it lacerated? Is it fractured? Is it sprained? What is that condition? And that's the word you should look at: laceration, fracture, sprain, and go from there. So in this case, we're not going to look at right, we're not going to look at carpal, we're not going to look at tunnel, we're going to look at syndrome. That's going to be our keyword. Now, if you don't pick the right keyword right away, it's not the end of the world. You can just go back and go, oh, maybe I'm supposed to look up this different word instead, or maybe there's an alternative word that means the same thing that you can look up. So maybe it's described as a disorder, but it's actually under disease in the alphabetic index. So let's start with the word syndrome. We have a lot of different syndromes, as you can imagine. So we start in the alphabetic index, and the beginning of the word syndrome, I believe, might be on this page. At the very bottom corner, I have it. So syndrome, and it says see also disease. So what are we looking for? Syndrome, and this is our main term, and then we have indentations here for each additional further clarification that we have. So we're going to need to flip to our next page to find the word, I'm assuming, carpal. So syndrome, carpal tunnel. Let's see what we can find. Syndrome. Here's our B indentations. Here's our C. So, oh, here we go. Right here is carpal tunnel, G56.0. Now there's a little check mark here in mine. Now that isn't always in every single book, but let me zoom it in here. That isn't in every single book, but it's helpful in this book because what it's basically saying is, hey, double check this because you might need an additional character, which stands to reason because they don't have here right or left. And we're probably going to want to know right or left, right? Was it carpal tunnel syndrome on the right side or the left side? So we never ever code directly from the alphabetic index. We always verify it in the tabular list. So we're going to go now into our tabular list and look at this G56.0 and know, since we have this check mark here, we're probably going to need some additional characters, or there's going to be some additional guidance there for us. So here is our G56.0, and you can see it says that we need, and this is real tiny, it might not pick up on the camera, we need a fifth character. So these are all of the additional extensions that we have. We have carpal tunnel syndrome unspecified, right, left, and bilateral. So let's double check our report. What does it say? It says that this was the right carpal tunnel. G56.01, carpal tunnel syndrome, right upper limb. And next we need to find our procedure code. So our procedure is a right carpal tunnel release. And there's a couple of different ways that people can tackle finding a procedure code in CPT. So with ICD-10-CM, they have official guidelines on how, this is how you look up the code. You go in the alphabetic index, you find the main term, you'd verify it in the tabular list. There's actually not an official way you need to look up CPT codes. Some people prefer to use their alphabetic listing in the back. Other people prefer to go to that specific system and then decide from there in their table of contents, like what were we doing? Was it the digestive system? Okay, well, it was the stomach. We did an incision into the stomach and find the code that way. For this demonstration, I'm actually going to show you both. So the term that they're using here is right carpal tunnel release. So I'm going to check the word release. If I can't find release, I might look at something maybe like repair and then see if I can find it that way. So release. So here's release, and we have capsule, and carpal tunnel is right there. 64721. I'm going to write that down right now, 64721, so I don't forget it. So here it is, 64721. Now this isn't the full description here. So what we do in CPT to kind of, I guess, save space is we have terms, and I'll zoom you guys in here. We have terms kind of abbreviated. So this is the main part of this description: neuroplasty and or transposition, and then you see that semicolon. And when you see a semicolon in CPT, that means stop. And that stop means that here's where we can go for this code, here's where we go for this code, here's where we go for this code. So neuroplasty and or transposition. Now 716. This is the full description: neuroplasty, endotransposition, cranial nerve, and then specify, but that's not what we did. We did this median nerve of carpal tunnel. This full description is everything after that semicolon. So neuroplasty and or transposition, stop, go here. Median nerve at carpal tunnel. So 64721, that's our code. 64721, that's right. We're verifying. Does it say that we should, oh, there's some additional guidance here. Do not report 64711, 6618, 64721 in conjunction with 11960. Okay, so that's fine. Nothing else that we need to be too worried about here. It doesn't say to add on an additional code for any other section that was done here. So 64721 looks like it's it. Now, the way we could also find this in the table of contents, and I'll show you that right now, is let's go to the table of contents. So here is our nerves, nervous system. So here we have a listing of the nerves of the skull. Nope. Spine. Nope. That's not where we are. We're in the median nerve of the wrist. Okay, so extracranial peripheral nerves and autonomic nervous system. And here is where we have neuroplasty. And that's what we did. We decompressed those carpal tunnel nerves. So that's how you would find it in the table of contents. This one's not as obvious as some of the others are, but that's where it is. We did this decompression of the carpal tunnel nerves. Now, we're not quite done yet because we also have in CPT what are called modifiers, and they're 2-digit codes that modify the procedure code. The modifier that we're going to need in this case is going to clarify that this procedure was done on the right side. So just because we have a right-sided diagnosis doesn't mean it was a right-side procedure as well. A good amount of the modifiers are in the inner flap of your CPT book. They're also in Appendix A for the full descriptions, and then there's some that are actually in the HCPCS book. So for this one, these are our RT. So RT means it's the right side of the body. So we're going to add that on as a modifier to this CPT code, modifier RT. So now this case is fully coded out. We have our diagnosis of G56.01 and then our CPT 64721 with the RT modifier, and then we're going to enter this into our billing system and send it out to insurance for payment. Now this case I want to show you because it demonstrates a little bit how you have to think a little bit further with medical coding, that the diagnosis lookup is not going to always be exceptionally straightforward. So in this particular case, we have a patient that is coming for a colonoscopy screening. This is a 55-year-old female who is having a colonoscopy to screen. We're doing a screening because there's different types of colonoscopies. There's diagnostic and there are screening colonoscopies. So diagnostic is we're going in to diagnose something. Screening is we're just looking to see if there is anything. There is no family history. That's going to come into play. No family history of colon cancer. Has been no blood in the stool. So there's no symptoms here. This is just this is truly a screening colonoscopy. The patient isn't having any symptomology. There's no high risk. So it's just a screening colonoscopy. And again, procedure performed. We don't just want to code just based off this. We can use it as a good jumping off point, but we want to always verify in this procedure note, this body of the operative report, as I call it. So colonoscopy to screen for colon cancer. Here's the prep. They did fentanyl. And then we did the tip of the endoscope. So that endoscope is that long scope that has a little camera on it so they can see as they're going in. Endoscope was introduced into the rectum. Retroflexion of the tip of the endoscope failed to reveal any distal rectal lesion. So that means there wasn't any little lumps or bumps or any tumors that they found in there. Sounds like there was a good, clean screening colonoscopy. The rest of the colon through the cecum was well visualized. Good. The cecal strap, ileocecal valve, and light reflex in the right lower quadrant were all identified. There was no evidence of tumor, polyp, mass, ulceration, or any other focus of inflammation. Adverse reactions, none. Impression normal. Colonic mucosa through the cecum. There was no evidence of tumor or polyp. So good. So this was an encounter for screening colon cancer. So now we're going to need our diagnosis, right? So what's our diagnosis? And then our CPT code. So what's going to be our diagnosis here? Because this patient didn't have any symptoms. We didn't find anything, right? We didn't find a mass. We didn't find an ulcer. There's no polyps. They didn't have a family history. So what are we coding here? Well, this is something that we call an encounter for. So it is an encounter for screening colonoscopy. So in this case, there isn't really a diagnosis, but we have a status code. So we have these Z codes that are status codes. They're things like you have a family history of something. You're at higher risk of having a disease. You are receiving an encounter for your routine physical, an encounter for a GYN physical. And in this case, this was an encounter to screen for colon cancer. So we're going to start with our encounter. This was an encounter to screen. We might also find it under the word screening. Those are some of the words that I'm thinking of that we should start looking at when we're trying to find this in the alphabetic index. So we're going to start with encounter. So here are our encounters, and if we go to encounter and then we go to our next indentation, so we have adjustment, we have administrative purposes, we have antenatal screening, we have assisted reproduction, breast implants. Oh, wait, here we go. Colonoscopy screening, Z12.11. Now I'm going to write that down so that I don't forget it. So Z12.11, and I'm going to verify that in my tabular list. We always verify in the tabular list. So here we go, encounter for screening for malignant neoplasms, and this is Z12.11, encounter for screening for malignant neoplasms of the colon. And that's what we were doing the screening for, to make sure that they don't have colon cancer. But there's a little note here. What does it say? Use additional code to identify any family history of malignant neoplasm. Well, this patient, it says here, they had no family history. So we don't have to add that in because there was no family history. So this is the right code, Z12.11. Now, CPT. How do we find that one? So let's check our index in the back, and we'll just look at colonoscopy because that seems like the most obvious thing to look for, right? So when we look at colonoscopy, there's all different types. There's flexible, and then there's the ablations. We didn't do ablations. We didn't do biopsies. Placement of a stent. I'm actually not seeing a screening code. Isn't that interesting? But maybe we could find something around where these codes are. So let's do this one where we go to the digestive system and look it up that way. So usually with these chapters, they kind of start at the top, meaning start at the head and then go to the feet. So lips, tongue, and colon will probably be towards the end. So here we are, colon, incision, excision, destruction, endoscopy. That's what we did, endoscopy. That's going to be page 368. So we have proctoid sigmoid oscopies. So colonoscopy, flexible diagnostic, including collection of specimen by brushing or washing when performed separate procedure. So this is when performed. So that when performed means we don't have to do it, but when we perform it, that is included. So let's actually, this is a great tool, is the colonoscopy decision tree. So decision to undergo colonoscopy, is this diagnostic or therapeutic? It is diagnostic. We went, let's see, did we reach the, does not reach splenic flexure, beyond splenic flexure, or to the cecum? So let's go back here. Did we reach the cecum in this case? We did. The rest of the colon through the cecum was well visualized. So that's it. So this is what we're doing here. We have this one to the cecum, colonoscopy, 45378. So that's the code we're going to use. 45378. Now, the other thing to consider with this is that depending on this patient's insurance, they might have different codes. So if this is a Medicare patient, Medicare has their own screening colonoscopy codes. So those codes are not found in your CPT book. They're actually found in your HCPCS book, and they are G codes. So if you look here in your HCPCS book, this is the codes for colonoscopy cancer screening, and they want to differentiate for Medicare patients. Is this a patient at high risk or a patient not at high risk? Now, high risk would be like they have a personal history or a family history. This patient didn't. So we would code this as a G0121, not at high risk for this patient if they have Medicare. So medical coding is not just looking up the term, finding it in the alphabetic index. There is some analytics involved to appropriately map them to the right code and verification, and then even being able to identify deficiencies and communicate those with providers. I hope you found the hands-on demonstration helpful. Now, do you need more practice? Because if so, I have got you covered. Check the link in the description below so you can download my free beginner practice sheets. So what questions do you still have about medical coding? Because I want to know what your burning questions are, what I didn't cover that maybe I can cover in future videos. Definitely let me know in the comments below. Guys, don't forget to like, share, and subscribe. I will see you guys in the next video. And until then, just keep on coding on.